Yeah, can you see that?
I can. It looks subcutaneous,
Yes.
but I don't know what it is. It
This
looks as though,
this is on a forehead,
oh,
and
is
it's
that?
and it's just a little bit of fat, but it's not in the subcutaneous layer, which is here. It's just under this fascial plane that runs directly over the scalp, and it's just a little
So
lipoma.
the periosteal border is the first hyperechoic line.
First bright line there, yes.
Yeah.
That's the
Okay.
periosteal border. And then there's a thin fascial plane that runs over there, and you just got a
Huh.
little bit of fat. And it goes by an unusual name called a subgallial lipoma. And it is,
Subgallial.
yes,
Painful or just
no,
frustrating?
no, just innocuous, just innocuous, just one of those things that you come across. Uh, uh,
Say the word again.
Subgallial.
Subgallial.
Yes, and I see them rarely enough that I have to sort of re-remember them. Uh,
Now,
yes,
is it round?
yes, yeah, it's sort of disc shaped,
Yeah.
like a very shallow saucer.
And it's hemodynamically static.
Yes, yes, definitely. Right, so let's have another look. We'll go to the 14th. And now this is just real bog standard stuff. This is a subacromial bursa that's got a bit of rubbish in it. And you can see it there just under the ligament,
Yeah.
the ligament, just untidy. And there you see infraspinatus with its tiger striping.
Ah,
We see very nicely the way infraspinatus, particularly with a little bit of edema around there, just gets this
yes.
very looks very like infraspinatus. This is infraspinatus, but that subscapularis has the same appearance.
Yes, it
But
does.
you
And
see
yet,
it less often in infraspinatus unless you really get good views and a little bit of edema, probably
whenever
set.
I whenever I see that, John, and I use the term interdigitated with supraspinatus, you give me the head shake and you go, "No, that's not it. That that
No,
that 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 this
that
is
is infraspinatus. I see on ultrasound very little interdigitation. What you see mostly is infraspinatus lying on top of the upper border of it.
yes."
Infraspinatus lies on top of supraspinatus, and you see those fibers very clearly as short axis fibers with the long
So
axis fibers of supraspinatus, the posterior part of supraspinatus lying underneath them.
let me throw this out, and I know you. I know I want to just restate it and get you clearly going, no, it's not that. When the reflected head and the direct head of the rectus femoris depart from each other, we get that black. And when we're dealing with like the biceps femoris and the lateral collateral ligament, we get that that anisotropy, whatever. And I know in the subscapularis we think it's the fascicular muscles that are growing up the fibers there. What you're seeing here is not anisotropy. This is literal structural separation, just because that's what happens at the infraspinatus. That's what you're feeling.
I think it is you'd have to take it on an individual basis, but you see
Right.
this ribbing there,
Yes.
and it might be muscle coming up in between, or it could be a little bit of edema that's tracking along the
Yeah.
septations within there, because you get this appearance when there is some background inflammation or background tendinosis.
But
More,
what it's not is supraspinatus going into it, because
no,
is the strands what you're showing me here a differentiation between supraspinatus below and infraspinatus on top?
yes, in the supraspinatus fibers there are
Yes.
going in one direction, and the infraspinatus is there. I know there have been various studies to show they interdigitate. I suspect if people ever go back to them and look at them in detail, that will be a somewhat localized effect, because you couldn't get large amounts of bundles going through there. There might be some fibers crossing over or continuous with, as you see a lot of these fibers spread out as they approach the insertion, and that might be quite close to the end. I suspect that doesn't really happen, even this, which probably a centimeter or something like that. In tendon terms, that's quite a big distance, because certainly on ultrasound at the macroscopic level that we're looking here, the tendons are separate and going in different directions until probably very close. But that's somewhere where I disagree with what I see disagrees with what I see published. But the devil is in the detail, and would probably not.
When you do the reps that John Leddy does, I have no problem encountering even academics in what they tear down in a single cadaver to be evidence that this is it. Another question for me while you're on this anyway. When it flattens out like this, we've historically called that the middle facet, as opposed to the superior facet of the three facets on the humeral, the greater tubercle. Do you give any credence to that? I mean, as you look at the slope angle, there are some people that will say, now you're off of supraspinatus and you're on to infraspinatus because the angle has flattened. Am I making sense to you at all?
You're making sense to me. Do I agree? Probably not.
Okay.
Or no, that's not. It's not true that I would disagree. I just wouldn't based on what I see, that would not be how I would choose to describe it. I'm just trying to see if I can see something, a case that would broad partial thickness tear. No, that's an injection. Bursal side supraspinatus tear. Let's see. I'm just going to have a quick look through this one to see if you can get a sense of it. Whether I go far enough round. No, not really. Why don't we? But I'm just going to have a look at this one, just as I'd need to find one that shows the points. But you'll just have to use your imagination, I think, to get what I mean. This is a short axis of supraspinatus. Yeah.
Yes.
Not a good one, but this section here, and you see the tubercle rise up. Yeah. So supraspinatus is inserting in this area here. Yeah. Think of a Y. If you imagine when you look at the ball, the supraspinatus is in a Y across here.
Yes.
If you think of a ball drawn round a Y, that is supraspinatus is the attachment there. That extends down into almost to a point. So it's like a tadpole shape.
In the direction of the middle facet?
Well, it's going in the direction of, you've got the attachment of supraspinatus, where you've got biceps in the corner here.
Yes.
And you've got the bulk of supraspinatus, that anterior portion, 7 millimeters or so of thick tendon. And I've got some good examples. I'm not sure why they haven't popped up for me to look through. And then it tails off in short axis.
Yes. And
the posterior fibers of supraspinatus are actually the deep fibers, and infraspinatus comes across the top obliquely. And somewhere I've got a nice video of that, but I don't know. I can't remember what I called it. So I'm just going to flick through some videos, see if I've got something that shows it just on the cuff. Yeah, if you use your imagination here, you've got the front of supraspinatus there, and then supraspinatus follows this line here, where you've got the tear. Delineates it, and infraspinatus is coming across here.
how far toward Longhead is infraspinatus coming?
Well, in this case, it's coming to here to about 8 mil. That must be about 8 millimeters across there.
Okay.
So within about 8 millimeters, I would have said roughly. So it's just like if you got a hand there, it's that supraspinatus, and then infraspinatus lies like that, with the biceps being here.
Yes.
And so yes, you can. The bulk of infraspinatus going into the back of the posterior side of supraspinatus, of the greater tuberosity, and the bulk of supraspinatus going in at the top. But the area crosses over like this.
We see deltoid at the top. We then see the thickened, or at least what looks like the bursa, and the tissue between. Are you two medial for the rotator cuff cable?
No, it's the rotator cuff cable will be. You can't see it on this one, but it will be in a line down here, just overlying the cartilage, going right across, and then sliding up here.
It'll be 90 degrees to the fibers of the short axis supraspinatus.
Yes. Yeah. It'll be and let's see. You can usually, if I'm looking for it, it's one of those ones where if you're looking for it, full thickness tear, that's not going to be any use. Blunt trauma, supraspinatus car boot plate. Let's see if this one's got something on it. I need to have a little look. Anterior supraspinatus full thickness tear. Let's have a look. No, it's gone in that one, so there's no point looking at that. What we need is a good simple partial thickness. No, that's an injection. That won't have it on. Let me come back to that one, as that needs picking out a case that shows it nicely. So I'll put that on my list of things to dig out for you next time, or I'll just do a quick video of it. I don't think I'll just write cable in here because I might have done a case where rotator cable. Let's look. Let's have a look at that. So certainly right. I should have just Googled there. Yeah, can you see there? Pointed out to you that it takes a little bit of seeing. So here, you see the biceps? Yep, good. So this is, it's a quite blurry picture, so it might be better to see when you're on a PC. But you've got the biceps just there.
I'm seeing if you're showing me the cable there.
No, I'm just showing, this is the biceps.
Yes.
Yeah, and then as the video runs, there's the cable.
Yes.
Yeah, running across there, and you can see the linear fibers going a cross section to the biceps.
So now they will call that, at least, is it above that where we have the coracohumeral ligament?
This is a little bit proximal to where you'd normally be looking for that.
Okay.
I am not an expert in that at all.
Okay.
I normally think of if we get will we see that as we come through? I haven't really got the best angle for. No, I've kept there on the cable. The cable's just a little bit set back.
Yes.
So somewhere in here, or perhaps in here, there might be some there. But the cable's normally a little bit more proximal than where you see that, or where you look for the coracohumeral ligament, because you're seeing it as it really comes in, and then it's attaching into the lesser and greater tuberosities.
You mean the CHL?
Yeah.
Is this an average thickness, John, of the cable?
I would say personally, I think that's probably a little bit more prominent.
All
Prominence
right.
enough that I pictured it and labeled it. But you know, sometimes if you look, this is in the other plane now. This is long axis on biceps, and there you see it.
Wow, I like that. That's helpful.
If I run through this one a little bit, so it's not obviously that the angles are not great. So but you
Yeah, I
just see it
understand.
through there. So there. So you're picking it. So you can see how far back it is from the
To
the
set.
impression,
Yeah.
which is why the coracohumeral ligament's probably gone south quite a lot. It's going in the other direction. So, but yes,
Fascinating.
you don't often see it that well, and it really takes the eye of faith there. But you can see that cable, particularly if I move it reasonably fast. You can see that hopefully popping out just there. So yeah,
Take me back to long axis on the cable and short axis on the supraspinatus, and talk to me about what you're going to call anterior fibers of supraspinatus.
Okay. This here, this bundle here,
Yeah.
very discrete bundle of supraspinatus. So that's the anterior fibers.
And the posterior fibers will trail off like a tail of a tadpole to the right here.
Yes, you can probably almost
under
make
the
out the line.
infraspinatus.
Yeah, and infraspinatus will be coming over the top. I'll pick out a video because it's very obvious in a lot of cases when you angle the probe to see it. All I just need to take next time I'm scanning a reasonably thin shoulder, I will just do a quick video for you where I transfer. I've got one somewhere, but I think it might even be on. I don't go on Twitter anymore, but certainly I posted one on Twitter where I followed it in and came in at once. But I'll look for it, or I'll just video another one because it's always there.
Yeah.
But you just have to really you have to play with the angles so that you get the anisotropy on one nicely,
right,
and a very good return on the other, and then you see this pattern.
I would like that.
Yeah,
all right, I want to have you wow me by the stuff that you wanted to share instead of me.
Well, I'm just let's see. I'm just trying to pull up stuff that you won't have seen.
I feel like you have to do anything. I'm the
no, but
here.
It's nice to have rather than have to claw through. This is a bit of a ropey video, but this is something I look at. This is something that I look at these days specifically, and that's the appearance of the muscle around infraspinatus. So I scan the muscle of infraspinatus here pretty routinely. So you're going to have to eye of faith. This was just a quick clip I took, and I wasn't really thinking too much about what the poor person who looks at it was going to have to go through. This is infraspinatus.
Yes.
Towards the back of infraspinatus.
Yes.
Yeah. So towards the spine, and this is me coming in, not very elegantly, and this is just wasted here. So the wasting is actually in different parts, and you often see that. It'll be part of the muscle, maybe proximal or distal, will be usually the more distal part is heavily wasted, and the proximal part is not. And whether that's because there's some variation in the innervation, I don't know. And then so you see that bright. This should be normal infraspinatus muscle, but it's very, very bright. This is actually because it's torn distally. The tendon is actually torn off. But if I come back, you'll see the contrast between that and the teres minor. So that's teres minor with its lovely, healthy staple. And this is infraspinatus here, which just looks like a.
So, yeah, I love that. I scan all three of those as a routine on all
Yeah.
of my scans, primarily because I believe I can gather a lot of information as to how healthy the muscle is simply based on its reflectivity. And you know, you can see, you can verify whether or not a tear has really affected performance if you don't see fatty infiltration. You know, even though there's a tear, that muscle is certainly still giving good effort to keep the, you know, the cobwebs of fat out of there.
Yeah.
So yeah, this is very valuable to me.
Yes, I do like to look at the muscle, and it's just part of the story. Let me just I'm just looking through. Uh,
How much supraspinatus imaging do you do muscle belly, and are your eyes looking at the actual meat, or are you looking at, you know, in the case of when you scanned the short axis infraspinatus, you know, you could see the glenoid and that kind of stuff. How much labrum assessment are your eyes doing, or any of the neurovascular bundles, that kind of thing?
I look for, if we go supraspinatus muscle, uh, big screen. So this is a very dark picture. Uh, this is a wasted supraspinatus. So in my standard scan, I start right at the medial scapula, and I come down it like this, and I'm looking at the quality of the muscle, the amount of muscle in there as we come down, and the amount of fat. Steve Bird describes the amount of fat
Yep.
you get here
Yep.
as being a marker of the degree of wasting. I don't necessarily think that's always quite so useful, but I do like it as a yardstick. You just go, that's a lot of fat compared to the not a lot of muscle. And
John, help me understand, because I guess let me try to say it like this: the echo signature of that fat, which is dark and kind of wavy, looks not too much unlike the same darkness that's under the wasted supraspinatus. How are you confident? I mean, I know you are, but how can a refined sonographer's eyes give me what nuances to the picture of fat verifies it as fat? It's not just anatomy. You're actually looking at it going, well, that looks like fat, Fritz.
well, if you look, it's all those things. It's the direction of the fibers. You know, it's the architecture within it. Looks like fat. When you
It's
change it,
lobular.
yeah. Well, the fibers are not linear.
Yes.
And they're not. And when you change the direction of the probe, you don't get a very much. It's going in one direction. It's dots. It's lines. It's dots. It's lines, and you get that in muscle. You know, you turn it 90 degrees and you go through line into dots. And when you scan through it, if you're not sure, you just scan through it and you see, because dots should all come together. They're always going somewhere, and they're generally all going in the same direction, and you don't get that in fat. So these are the markers when you're not sure, and you're often not sure whether it's fat or muscle. That's what you're doing. You then optimize your picture to bring out the dots. And then once you've optimized it for the dots, or in fat, you often can't. But there'll usually be a muscle next to it, and you'll go, well, that's really muscle, and because it does that, and I can't get that on for that other area, so it's going to be fat until proved otherwise. Except
dynamically scanning it, looking at the reflective components inside, you're able to tell, do the strands follow a line? And if I move it from one direction to a 90-degree difference, there's not a lot of change in the echo texture in fat.
Yeah, that's exactly right. That's what you see, and that's what you see. What this is an old video, so the picture quality is going to be a little bit ropey, but yeah, this is a good one. This shows you what I want to see. So this is an intramuscular lipoma, and there is a very common
in the calf.
Yeah. No, it's this bit that I wanted to see. It's quite bright, and that's because there are but look at the fibers. You would think that was muscle.
Yes.
So this is a case there's a group of intramuscular lipomas that have this very thick, made up of very thick, bright, almost tendon-like collagen fibers that run all the way through. And it doesn't make them any more or less likely to be anything unpleasant, but they are but it looks so like muscle, but just so like all the muscle around it. And actually, the fibers don't join up with muscle, which is what tells you that it's not just part of the muscle.
Are you feeling that this is not a remodeling / degradation of muscle, but this is an actual growth of its own collagen?
Yes, when these get taken out, and they do routinely, they are lipomas, so basically fatty lumps with a fibrous component.
And how much credibility? I mean, you take it out with urgency, or when you see it like this, are you just saying, better off taking it out? I didn't see a lot of activity on Doppler. Does that matter to you?
It would matter to me. I would be. I'm not. When I see these things, I'm not normally in a position where I'm making those sorts of decisions. I'm just seeing them and sending them off. But if they have a lot of color, if they have much color flow in them, then they go off with a blue light on it. And if they don't have a lot of color on it, they go off, and they probably still will see the surgeons about it, but it doesn't have that sense of urgency.
Was this painful, or just got in the way?
No, they're not. If they were painful, I would be more concerned. But they're not. They're not generally. They're just fatty lumps. They're just lipomas, and it just happens that that's a common thing for a lipoma to be like.
There's crud inside of crud.
Yeah.
Orient me here.
This is the radial artery, or where it divides in the wrist.
Okay.
And then there's just a little bit of there's just a funny little lesion there with very thick.
Like a ganglion, or I guess it's too thick a wall for ganglion, and it has junk inside.
Anything that doesn't look just plain and simple is not a ganglion.
Gotcha.
So
this really is a cyst of some sort that has a cyst inside.
Yeah. Yes, and I don't know what it is, but it's probably a pseudoaneurysm that is sealed up, because so it's basically a hematoma of sorts, but an unusual shape of hematoma, probably caused by a burst in the wall of the blood vessel of an artery, and then so fluid's been pumped into it, which gives it that big thick thing with and as the thing has closed off, the jet has got smaller and smaller, and so it's just left you with a little bit of fluid in just eccentrically within the circle. So it hasn't. So the fluidy bit isn't right in the middle. It's just off to one side,
Now, was the grayscale of the image part of why you thought that it was blood, or were you saying that that really is the mechanism anatomically to what those things are?
Yes. Yeah, definitely seen similar things before, and that's what it looked like. I would never say that's what it was, but I would it would be, that's what they look like. That's something that you recognize as being similar to what you've seen before, and therefore, not that video. Let's have a look.
Now, you said you would not say that's what it was, but
No.
do your images go to somebody who will then call it that?
No, they don't. It's just I will say that it resembles that, and I will say that the images are not specific, but this resembles a sealed off pseudoaneurysm, and that will go
Where
off.
does it?
That would probably go
Well,
off to a vascular surgeon just to make sure that it's for an opinion.
I gotcha.
So yes, there's no. That's a little one. So I'm just got some pictures up of ganglions, and so because this is an area where we often see, and most of the pictures I've got of ganglions are of me sticking needles into them. That normally don't. Let's have a look. Because ganglions are so straightforward that you don't normally bother saving it. What you have to watch out for is this texture within it, because that could easily be a solid lesion that just looks dark enough that you call it a ganglion, and we see that a lot, even by quite experienced people scanning, is that they mistake something for something like this, which is a ganglion, but they've because there's debris in it, they just presume it's debris, whereas in actual fact you just may not have got the gain up high enough, and it's actually a vascular lesion, because you get vascular malformations and that look very dark on ultrasound, and then if you aren't careful, you'll say it's a ganglion, and someone will put a needle in it and have a lot of trouble stopping it from bleeding.
Wow. Now, would they find it hemodynamic if they would have just put something on it, or that large of a structure, is it not showing flow?
They often don't show a lot of flow because they're very low. The velocity of flow is very low in them.
So what do you do? Do you push
make,
up and down? Do you push up and down on it and try to make the debris move, or how do you?
You do that? It's not always very successful. What you do is you turn the gain right up, and what you don't want to see is something homogeneous. That a low level echoes, but all the same amount can often be a solid lesion. I think I have an example actually. If I yeah, that looks very much. I've seen those called as ganglions. Yeah.
Oh yes.
Yeah. People say that's a ganglion, and then you see some blood flow in it if you press very, very gently. But yes, you would not expect that to have blood flow in it, and
wow.
But you have to look really carefully to see blood flow. And some of these vascular malformations, they don't have any blood flow in at all, and they've got, because they're mostly blood, but in convoluted vessels, they actually look like they're very, very dark with very little solid elements to it. And so it's just somewhere where you have to be careful, and you have to know and trust your kit and turn the gain right up. So you can get caught out by that. And it is a problem we see routinely in departments where inexperienced people are scanning lumps and bumps, where they will call things that are ganglions and they're just not. And all the time around, often around the hand, we see giant cell tumors.
Oh my.
Are you familiar with that?
I only think that has, I mean, that's an urgent type of a cancer,
No,
or not so?
no. It's mostly problematic. They take them out when they find them. Certainly,
Okay.
they take them out and they find them. But this was one that was called a. I think this was called a ganglion in radiology, and then when we scanned it, it was a giant cell tumor. So yeah, similar to the last one. So this is a giant cell tumor is not a cancer. It's a proliferation of the synovium. So you get them a lot around the hand, where it's a form of PVNS. If you
Yes.
do that,
Yes.
yeah, it's like a very focal form of PVNS, and
Okay.
very common around the hand in particular, but sometimes in the foot, and you get these lumps. Sometimes there's no color in them, but you just have to recognize that ganglions in the hand are clear. They're not. They're properly black, not this dark gray. And to say this had been scanned on a radiology scanner, and they'd seen no blood flow in it because they hadn't. So when I scan them, you'll usually see a layer of jelly there showing.
Yes. Yes. Yes.
So I'm not pressing on this at all. And even the pressure of the probe through the jelly can reduce the amount of blood flow you see in these. So you really do need to earn your corn.
Wow.
That's another giant cell tumor. Anything that looks like that around the hand is very likely to be a giant cell tumor, unless it's right up by the nail. This was an unusual one in that it's actually sitting over the de Quervins, over the first compartment.
Huh.
See?
Huh. And that was a giant cell.
I think so, yes. I don't know whether I got histology for that. But almost certainly, based on its position, it's almost certainly a giant cell tumor.